everyone. Thank you for joining. My name is Mariam Hussein. You all may remember me. It's been a while since we last saw each other. Thankfully, we haven't had a need to have a webinar, every month like we used to before, every other. But alhamdulillah, we're in the new year now, and we're joined again by a very good friend and expert, Dr. Uzma Syed, for the CME on look back at COVID and look back at 2020. So first of all, Bismillahirrahmanirrahim. Thank you all again for joining. I know that this is the COVID is the first thing we want to forget, but unfortunately, it's still part of our lives right now, which is why we're having this webinar. And it's been a very long year. We've learned a lot throughout this year. A lot of things have changed because of what we learned. And unfortunately, we've also seen a lot of tragedies too throughout this whole pandemic as well. But I think if this time has shown us anything is that there's a lot to be hopeful for, and there's a lot to look forward to in the future. And nothing is, that statement I don't think is any better represented than with the vaccines, that we've been able to have. So that's the point of this webinar, is just to give, again, an update. A lot of stuff has happened in the last few months too, just with updates in the vaccines, things opening up, should things open up. Unfortunately, we see a lot of stuff going on in other parts of the world. So inshallah, we'll have Dr. Syed give us a well-rounded perspective as to what we should expect and all that. And also what to look forward to as well. So if you have any questions, please put it in the chat, put it on Facebook, whatever social media you're on right now. And then inshallah, we'll be able to get to it at the end. All right, so without further ado, Dr. Syed, thank you again.
Thank you so much, Dr. Hussein. And I want to thank IMANA first and foremost for really keeping people informed and having these regular webinars throughout the most difficult times in the pandemic, where people really were lost and looking for trusted resources, which I think is so important with all the misinformation that's out there. So, it is a blessing, alhamdulillah, that we are able to do this less frequently. That's a good sign. We are making a lot of progress. We have come a long way. And for the next hour, I'm just going to share basically, the past year, COVID-19, a year in review, and in things that may seem like really distant, and how we kind of coped with all of that. So I'm going to go ahead and share my screen here. Give that a second to load. At the end of the presentation, I'm hoping that we have some time. There is a lot of information to get through, and I really could do this over 3 or 4 or 5 different talks because there's just so much to cover with COVID. But I will also leave my information, my social media and contact information. If you have any further questions, please feel free to reach out. So going back to the beginning, on December 31st, 2019, the WHO China country office was informed of cases of pneumonia of an unknown etiology, which was detected in Wuhan city in the Hubei province. And from December 31st till about January 1st, we had about 44 patients with pneumonia of unknown etiology that was reported from China. And during this period, we really didn't know. And very quickly, we started seeing images like this surfacing, in the media, where there was this mysterious illness reported out of China. And, there were links to a wet market, and it seemed to be at that point pretty much contained, but it was still pretty much a mystery. By mid-December, people started showing up at hospitals in Wuhan with strange findings clinically and on their imaging. So we had people coming in with respiratory symptoms. Most of them initially were really traced back to the market. On December 24th, a sample from a patient was sent to a private company about 500 miles away from Wuhan. And that's where this company was able to actually produce the genetic sequence of the virus by December 26th. And that sequence was very similar to SARS back in 2003, which we had dealt with. And SARS, we had unfortunately about 8,000 people that were affected worldwide, and over 700 people that were unfortunately lost their lives from SARS. On 12/31, Chinese officials described this outbreak as viral pneumonia, but they had said that there was no evidence of human-to-human transmission. On January 3rd, the WHO was told that the Chinese government had then identified about 44 cases of this viral pneumonia. So on January 11th, then the WHO had then received the genetic sequence for this novel coronavirus. And initially we were referring to it as 2019 nCoV. And, this was really, really important because to have the viral sequence upfront and very quickly was tremendous because, this means that you can really move quickly with diagnostics and therapeutics and really figure out what's going on and where we are with this. So if we look at a timeline, getting back to January, after these cases were first reported from December and then into January, on January 13th, we had the first case that was reported outside of China in Thailand. And this was in a 61-year-old woman. Now, it's important to note that this woman had no contact with the wet market in Wuhan because up until now, everything was essentially confined to this market. On January 13th, also, scientists in Germany had published a toolkit to really help other countries deal with this novel virus. On January 20th, we started seeing outbreaks occurring throughout different parts of China. And it's at this point that there was really concerns about human-to-human transmission, and about 198 cases were reported, and China did declare that there was, in fact, human-to-human transmission at this point. By January 23rd, we had 571 cases reported, and Wuhan quickly went into lockdown. January 30th, NIH had cultured the virus from the first case in the US and had started doing some research. Also on January 30th, the International Health Regulations Committee declared the virus a public health emergency of international concern. Well, a month later, we can see from the WHO's statistics here and the grid that we're so familiar with looking at initially, even in February, you could see that most of the cases were really just confined to mainland China. And this is what we were seeing, in January, in February, and this is when everybody was still pretty comfortable thinking that, this was something that was, even though we already had our first case here, it was not something that was going to be pronounced the way that, it was happening in China. And, most of us in my field were losing tremendous amount of sleep over this because of the potential of a global pandemic. Well, a month later, that was in February, this is in March, you can see the significant increase in cases worldwide. You can see obviously mainland China, Southeast Asia, Europe is completely affected by this, parts of the Middle East. And in North America, you can see that the cases are climbing. We're already up to 121,000 cases that were confirmed and over 4,000 deaths. And this seemed alarming in March. It was concerning at that point. We saw that there were cases going on worldwide, but little did we know, at that point, that these numbers still would look pretty good compared to what the situation that we're in now. So as of March 9th, the cases of novel coronavirus had passed 110,000 worldwide, and outbreaks were occurring and worsening in the US, Italy, and Iran, and they started to ease in China and South Korea. More countries around the world were announcing more cases. There were now more than 600 confirmed cases in the US, with the numbers that were rising in Washington State, California, Boston, New York, and elsewhere as more cases were going on across borders. And then we look at in May, the Johns Hopkins tracker, which we looked at almost on a daily, sometimes an hourly basis at what's happening worldwide to really keep count of the cases. And you can see the significant spread of disease. We went from 121,000 cases in March to over 3 million just by beginning of May, and widespread disease globally, reflecting just how transmissible this virus was. And if you look at these graphs that we've seen over the past year, you can really see the linear trajectory of the cases, of the hospitalizations and the deaths, as we're all really just struggling to keep our heads above the water during this tsunami. And this graph that we very frequently saw over and over, that we talked about in the beginning, of our first surge of last year, about flattening that curve. We went into lockdown because we didn't know enough about the virus. We didn't know exactly, what to expect, and we had to investigate. And we had to see how could we modify our behaviors to really control these cases in our health system, because our health system was really on the verge of a collapse. And we talked about that, flattening the curve, getting the numbers down. And unfortunately, we had to go into lockdown to really do some of that. And we look back at our pandemic response. We look back at, what things were done right, what things were not done right, and where could we have made improvements, and how really to come out of this with lessons learned and be better equipped and better prepared for the next pandemic. So we did find ourselves, quite ill prepared for it. Our knowledge was evolving on a daily basis, hour to hour, minute to minute capacity. We truly felt handicapped without having proper diagnostics. Forget about therapeutics. We felt helpless against those people that were just coming into our hospitals. And we were struggling to try to keep the sickest people alive. Our usual therapeutics that we have, to save them, our usual interventions were just not helping anymore. And we felt completely helpless. We didn't have that magic bullet. We kept losing our patients. We quickly started conducting research because science always guides us. And we knew that only evidence-based medicine would show us the way. But we still felt like our hands were tied. We couldn't just offer up any therapeutic that we wanted to our patients. We had to screen them. We had to see, were they eligible for these, clinical trials where we could potentially offer them some life-saving therapeutics. But, there were strict criteria, and it became very frustrating and very upsetting to keep losing so many lives and feel helpless in this pandemic. We didn't know about the mode of transmission. We didn't know, is this a droplet transmission like other coronaviruses? Was it airborne? We didn't have enough supply of PPE. We were, really being asked to be heroes and be these frontline workers when most of us had not been given that role before and were akin to, superheroes very frequently. It was nearly impossible task to write and revise policy as information was constantly changing. And we were learning about this virus on a practical, daily basis, hourly basis, minute to minute basis. But what we did was we kept the messaging clear that what we say today may change by tomorrow. But in a time of uncertainty, fears and unknowns and the lack of answers really leads to more anxiety, anger, and frustration and mistrust. And, we often found ourselves as healthcare workers feeling this way, carrying the burden, of the whole world on our shoulders and just struggling to just survive it on a daily basis while doing right by our patients. So diagnostics was really important in this time frame because we really couldn't get any headway without having proper diagnostics. So on January 15th, the CDC assured local and state public health officials from across the nation that there would soon be a test to detect this mysterious virus, that was first reported out of China. Unfortunately, it was not very easy to test patients because it was very difficult to ask and request for these test kits because it was restricted initially just for travelers out of China, when we knew initially that we already had some reports here. And very quickly, we learned how this was already widespread. On February 8th, the CDC test kit's first batch arrived at a public health lab in east side of Manhattan. By then, though, the virus had, already been circulating in the US. And unfortunately, these tests failed. And once again, we felt handicapped. And then the bureaucracy took over and delayed things further. About 20 companies were already in late January starting work on private test kits. And they were speaking to the FDA about their plans to develop tests. Unfortunately, at the end of January, Alex Azar had stated that COVID was a public health emergency. And at this time, because of that, these private companies had to request emergency use authorization from the FDA in order to use their test kits. So this just led to further delay. By February 4th, FDA had approved the test kits from the CDC, and these were really the only accepted test kit for the novel coronavirus. So states and cities across the US were receiving very quickly after this received FDA EUA, they were receiving these test kits, but the issue was that there were many issues with the test kits. So, unfortunately, we learned very early on that the reagents that were used in these test kits were problematic. These reagents are there to isolate viral genetic material and then to amplify it, but there were some issues happening with this when the samples were tested on a patient that had a virus. They were producing similar results as a sample that was tested that was essentially distilled water. So what did this do? This put us really behind. This let the virus really get ahead of us and keep circulating and transmitting in our communities. And we had other countries throughout the world, such as Singapore, South Korea, who were really just blazing ahead. And they were testing about 1,000 people per day by mid-February. And we were still dealing with test kits that were inadequate. So this was really crippling. This really put us behind. On the 29th of February, actually, the FDA did reverse its course, and it did allow private companies then to develop their own tests and start using it. And so this really helped us get ahead of this this problem that we had. So once we started getting ahead of the testing issue, we started seeing what were the other obstacles in our way as far as this response to this pandemic. Well, we know that there was huge gaps in our public health funding. We could see that there was tremendous problems in our healthcare system. The pandemic response was just not where it needed to be. There was a lack of infrastructure. There was a lack of investment in public health. It was really difficult for healthcare workers to be advocating for their patients and for the communities when there were people in the media who were downplaying the danger of the pandemic and really sidelining the experts and making comments that this was no worse than the flu or that this would be over by Easter. So the politicization of the pandemic and the amount of misinformation that was spread was really detrimental in this as well, really letting this virus get ahead of us and, unfortunately led to significant loss of lives. Now, we remember at one stage where we had so much surge of this virus and hospitals and healthcare systems were overwhelmed and we were running out of critical supplies. Mechanical ventilation is the backbone of critical care for patients with severe acute respiratory failure. And we had shortages because we've never had this kind of situation, in the past 100 years. We've never had this volume of patients coming in simultaneously with this acute illness. 50% of the cases that were admitted to the ICU required some form of mechanical ventilation. So manufacturers really stepped up at this point. They ramped up their production to meet increased demand. We had companies such as GM, Ford, Dyson, Rolls-Royce, Tesla, all really making efforts to create ventilators. And, by July and August of 2020, it was hospitals across the US and health systems were required to display the number of ventilators they had in their facilities. And quickly, with the enactment of the Defense Production Act and with private companies really stepping up, we were able to increase our ventilator supply from 62,000 to 120,000 in our stockpile. And then eventually we were able to donate to other countries as well. And this is something we're seeing right now happening in India. We are seeing the tremendous impact, that this virus is having and the lack of supplies, simple supplies such as oxygen, that is just not readily available. And we're seeing it in South America and other parts of the country as well. So one of the backbones of pandemic response is adequate testing, tracing, isolating, and quarantining. And this is really important. And again, so many hindrances with this because initially we just were not having the testing capability. And then we saw quickly how we didn't have the infrastructure to really do the contact tracing. This requires significant amount of people and a workforce. And, we were lacking in that. And we saw how much of an impact that had because then people were, especially in a virus that we know now has asymptomatic, pre-symptomatic transmission, people just kept, carrying around and, really transmitting this virus to others. And it just kept spiraling kind of out of control. Countries that followed this advice closely really succeeded in controlling their outbreaks. Other countries such as Vietnam, Thailand, New Zealand, South Korea. We saw strict, lockdown procedures happening in China, and they kept their counts low as well. But there has to be a fine balance. The other thing is some countries did well was to have quarantine hotels, and that really helped prevent further transmission of this virus. But you really need to have a system in place where you have supplies and you have resources for people that are sick that would need it. In New York City, the city's Test and Trace Corps had its Take Care program, which had put up roughly about 6,200 people in their local hotels since June. And as I mentioned, other countries around the world were also doing this, and the countries that were able to provide resources really were faring better, and they had better outcomes. But this is something that we should be able to provide to people everywhere. Then came the big question of masks, to whether these masks were really useful to mask or not to mask. There was so much confusion around the mask guidance, and that this created a lot of confusion and unfortunately mistrust as well. So in the US and globally, authorities were not recommending masks initially because initially this was, thought to be transmitted only by people who were symptomatic. So now many countries in the Far East, especially Southeast Asia, including China, Japan, had been using masks for a long time and had really normalized mask wearing. So this was not something foreign to them. And remember that they had experience with SARS previously in 2002 and 2003. So initially, the WHO and the CDC had said that the masks were not necessary for people unless they were experiencing symptoms or caring for somebody that had symptoms. This was before we knew about the asymptomatic or pre-symptomatic transmission. Also, people were being told not to buy N95 and surgical masks because we needed the supply for the healthcare workers, again, because we didn't have enough stockpiles. Well, the CDC changed its course and recommended cloth face coverings in April, and then the WHO recommended, again, face coverings by June. At this point, we had already kind of sent some mixed messaging, and, people were starting to have mistrust with authorities and the message that was coming out. Again, with pandemics and with novel viruses, with any, emerging infectious disease, you are doing things in real time. You are learning about it on a daily basis. So things are going to change. But this was something that people are not used to, not having solid, standard information that is the same everywhere. The WHO had actually released 10 considerations for effectively managing the COVID-19 transition. And I think the important thing for this was a transitioning back to some sense of a new normal, right? And so this was really important to approach this as a phased approach. Balance individual rights with social good, make sure you have support for communities, support for healthcare workers, have clear and concise communication. If you look at the US, our pandemic response was a little bit different. We really had a decentralized response. It was essentially left up to individual states and local leaders. There was no national strategy. And unfortunately, we saw massive spikes in infections and many local outbreaks, placing enormous strain on healthcare systems and really leaving no region untouched by this virus. We also quickly uncovered structural racism. It really fueled health inequities. The pandemic really brought to light these deep-rooted racial and economic inequities in healthcare. Black and Brown communities were disproportionately affected by COVID-19. Black and Brown communities had already suffered from high rates of underlying medical conditions such as obesity and diabetes due to inadequate healthcare, lack of access to nutritious foods, outdoor spaces, high exposure to pollution. They also comprised a large percentage of essential workers in frontline industries. And obviously, this made them the highest risk for COVID-19, as well as high risk for having severe COVID. They were working a lot of times in nursing homes, in meatpacking plants, in restaurants. And unfortunately, we saw very quickly how the lack of paid sick leave or hazard pay or childcare services, simple support services really put them at risk. And people unfortunately had no choice but to keep working through their illness. And this, in fact, led to significant amount of disease and significant amount of mortality in these communities. The MMWR had released some data and some studies on understanding really the social determinants of health and contributing to how they contribute to geographic and temporal differences in racial and ethnic disparities at local level, and how we can really use this to guide our public health strategies and have equitable resource allocation. And this is really important because not only did we see structural racism and health disparities just right from the beginning of COVID-19 and how this virus was impacting people disproportionately, we saw this theme continue throughout the pandemic, especially as we saw whether it was clinical trials for therapeutics or as vaccines became available and we saw the rollout of vaccines. This underlying theme was present throughout the pandemic. And these charts over here just show us really the disproportionate rate and impact on different communities. And you can see here this dark blue line on top really shows the impact on the Latinx communities, and then this followed by the next most affected Black Americans, and how significant impact this virus had on minority communities. And it's really important for us to have culturally responsive, targeted interventions with trusted leaders, community organizations, and communities of color to really reduce these disparities with COVID-19. And we need to continue to invest in communities of color to address the social determinants of health, most importantly, because this is something that is going to be with us for a long time and has been around for a long time. And we have to figure out how to fix these problems, how to move forward from here. So there are many challenges that are facing minority populations, which really hinder access to healthcare. If you take, for example, a person, if they're a single parent or even a dual working household whose healthcare maintenance was deterred because of challenges in transportation. Having a car is a luxury for many people, and most people that take public transportation, it's quite difficult. A lot of people have to change multiple buses. It's not very simple, and these buses are often unreliable. And oftentimes when people arrive at their appointments and they're arriving late, it's very common now to have policy in place that if you're 15 minutes late, 30 minutes late, your appointment is immediately canceled. And so now you've gone through all these hurdles and obstacles as a single parent, or even as a dual working household, to take time off of work to arrange and try to get on all these public transportations to make it to your appointment, only to be told that, yes, you're late half hour because your bus never showed up, your connecting bus didn't show up, and unfortunately your appointment is canceled. Well, what does this do? This deters you from seeking healthcare. You stop taking your medications, your blood sugars rise, your blood pressure rises, you end up needing to be hospitalized emergently. Now you're considered high risk for COVID-19. These are things that we have seen characteristically, time and time again, and this pandemic just brought these to surface even more. Now, imagine if you are sick with COVID-19 and you live in an extended household, multi-generational household, where you are living with your grandparents, your grandmother, your spouse, your kids, and your kitchen is the same as your living room, and you share one bathroom. We are telling people to isolate if you're sick, and how do you isolate from your loved ones when you don't have the luxury of having the space? So that's another hindrance that created this ripple effect. And then, childcare necessities. We didn't have these services in place for people to have access to childcare, for them to go get tested, if they were not feeling well, for them to really have time off, and isolate. All these simple services were just not in place and just kept driving the inequities even more. There was a study that was done in 2018 that also showed that Black American patients had improved outcomes when they were seen by Black doctors, and they were more likely to agree to preventative care measures for diabetes screening and cholesterol tests. So we know that in healthcare, especially, we know that there's complete underrepresentation of Black Americans and Latinx population as physicians. So this is another confounding factor to all of this. The next hurdle in our pandemic was the misinformation pandemic. This is to add to our uphill battle. We found ourselves constantly undoing the amount of misinformation that was circulating both within and outside of our communities in order to save more lives. Now, the things that did go right, treatments, definitely we very quickly early on invested in clinical trials to really have science on our side to find effective, safe and effective therapeutics. But we also saw that there was some struggles with this as well. There was difficulties in equitable distribution and delivery of these drugs, especially with antiviral remdesivir during the rollout, ability to enroll patients in clinical trials. We wanted to make sure that the patients, again, who are most affected by COVID-19 had access to this. But again, because of the structural racism and the history in our country, patients were reluctant to enroll in clinical trials because they do not have trust with the healthcare system. So once the remdesivir had received emergency use authorization in May of 2020, patients now had broader access to potential life-saving medication. So this was definitely something positive, where we were able to offer these patients this medication that potentially could be life-saving without having to enroll them in a clinical trial where they may or may not get the medication, where they may or may not meet criteria. So it definitely helped us along the way. So just a quick summary of the data from the ACT trial. It was a randomized double-blind placebo-controlled trial of about 1,062 patients, which showed that remdesivir was superior to placebo in shortening the time to recovery for adults who were hospitalized with COVID-19 and had evidence of infection. It shortened the duration of illness from 15 down to 10 days. And this was really important and really landmark trial for our fight against COVID-19. By October 22nd of 2020, FDA actually grants full approval, making remdesivir now the standard of care. So this is essentially available for all patients, except if they have some exclusion criteria based on kidney and liver function, but otherwise it's available for patients who are hypoxic and needing hospitalization for COVID-19. We also received some positive news from the recovery trial on steroid use. There was a lot of, questions about steroids because we had previous information from the SARS pandemic where we saw that steroids actually, usually classically steroids, prolong viral shedding and can be more problematic. And we saw in SARS that it didn't actually lead to improved outcomes. So initially we were not using steroids, and then that pendulum swung back and forth several times. But again, science really guides us. So we had evidence-based medicine that was guiding us to show us that from the recovery trial that dexamethasone actually in this large open label trial, they basically looked at 6 milligrams of dexamethasone in patients for up to 10 days. And the primary outcome was 28-day mortality. And about 2,000 patients were assigned to receive dexamethasone, and they found that it resulted in lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone. And the good thing about this is that steroids are inexpensive and they're readily available. And, so this was something that, again, was very helpful during the pandemic for us to really move forward. Now, convalescent plasma, we've talked about quite a bit over the past year, and the pendulum has swung back and forth so many times. There was really high hopes for convalescent plasma to be really effective, as previously looked at and had success in other viral pandemics. Unfortunately, the data was really mixed, and among patients who were hospitalized, who are not requiring mechanical ventilation, the studies had shown that high titer antibody level infused plasma may be associated with lower risk of death, in patients. However, the IDSA guidelines recommend against the use of plasma for patients who are hospitalized, and for anybody who's not hospitalized in ambulatory care setting, they just recommend only the use of plasma in the context of a clinical trial. NIH has actually said that the data is insufficient to recommend for or against the use of plasma. So again, really not the home run that we were hoping for. Moving on to monoclonals. So monoclonals were really of high interest. They were first studied in Ebola. They had shown some promise in SARS and MERS. And essentially the way that it works is it binds to the spike protein and prevents the attachment to the ACE2 receptor. So we have currently 3 FDA-approved under emergency use authorization monoclonal antibodies in the US. One was approved on November 9th of 2020. The second one, November 21st. Lilly Pharmaceutical has developed the bamlanivimab and etesivimab, and Regeneron Pharmaceuticals has developed casirivimab with imdevimab. And most recently, May 26th, EUA approval was given to sotrovimab by GSK and Vir. And so this has really been helpful in preventing progression to severe disease. So it's really been helpful for patients who do not require hospitalization. So these monoclonal antibodies actually are only approved for use in an ambulatory setting for patients who do not require oxygen, who do not require hospitalization for COVID-19. And there's a strict EUA criteria for administration of monoclonal antibodies. And, these, as I mentioned before, were initially approved under EUA in November. And the initial EUA criteria, actually, this one on the left, was quite stringent, where patients had to meet this criteria to be eligible. And the most common was, elderly, so age over 65, or standalone if you had any of these conditions: diabetes, chronic kidney disease, immunosuppressive disease. Otherwise, if you were 55 or older, the only way you would qualify is if you had any one of these underlying conditions, such as cardiovascular disease or chronic obstructive pulmonary disease. And then there were some criteria in the pediatric population. But the BMI alone was over 35. Well, recently, the EUA criteria actually has been modified, where the BMI now has been dropped from 35 to 25. And all of those conditions that you needed to meet based on, if you had to go by age and these underlying conditions, now they're all standalone. And in fact, there's actually language in there where if you are at increased risk for progression of severe COVID-19, for example, by race or ethnicity, you can also be eligible. So, and also pregnancy was added in there because there initially was just not enough data. So we do know that pregnancy is high risk for severe COVID-19, which is why we have been really promoting vaccinations in pregnant individuals to prevent, their severe risk, the ICU stay, and preterm labor that we have seen with COVID-19. So these criteria have been loosened, and now we have not one, not two, but 3 monoclonals that have been approved for use for COVID-19. And the other thing I will mention quickly is that initially Lilly had developed a single monoclonal antibody, bamlanivimab, but as we started developing variants, because of uncontrolled virus spread, we noticed that single monoclonal antibody therapy actually was ineffective for variants. So they developed the second monoclonal etesevimab. So now it's only given in combination, whereas Regeneron was always a dual monoclonal cocktail therapy that was given. And then we have some more information and updates from the recovery trial on tocilizumab. So tocilizumab, again, the pendulum swung quite a bit on this IL-6 blocker. There was a lot of interest initially during the first surge, spring of 2020. Unfortunately, the trials that were ongoing showed really not promising results. So very quickly use was limited. And then there was a trial that came out that showed possibly some benefit. And then in the end, we had data that came out of the recovery trial that showed basically that patients who were randomized to receive that had hypoxia requiring oxygen, significant inflammation, and if they had treatment with combination of systemic corticosteroids such as dexamethasone plus tocilizumab, that they had reduction in their mortality by about 1/3 for patients that were requiring simple oxygen, and nearly 1/2 for those who were requiring mechanical ventilation. So this was very helpful to actually have solid science, evidence-based medicine here to guide our treatments. Now, for more good news that we had, in this past year was really remarkable efforts on the vaccine front. We had, over 287 total vaccine candidates. And we had 102 that were in clinical trials, 185 in preclinical trials. I mean, the vaccine trials and works on vaccines just started essentially immediately from the second that the virus was first detected, and we had the genetic sequence of the virus in January. Scientists around the world really went to work on vaccine development right away. It was really remarkable to see. And this from the WHO just shows you all the different vaccine targets. So most, vaccines have different targets, but most of the vaccines, you can see that there's about 32 candidates that are targeting the protein subunit. And then you have the next more common is the viral vector ones. And then you have DNA and inactivated virus, and then RNA vaccines. So there's all different modalities. Now, from the World Health Organization, this is just a table that shows all the different vaccines that are in clinical trials that are at some point of their approval status. So this table over here shows all of these vaccines actually have gone through their clinical trials and have been submitted to the WHO and have had emergency use listing given to them, and these are the dates of when they were authorized. So you've got Pfizer, AstraZeneca, Janssen, Moderna, Sinopharm, and then most recently Sinovac also was recognized under EUL by the WHO. And then these are the other vaccines that are still pending. For the United States, we have 3 currently approved vaccines under emergency use authorization by the FDA that have gone through completed 3 phases of their clinical trials that have been proven to be safe and effective. We have the Pfizer BioNTech vaccine, Moderna, and the Janssen vaccine by Johnson & Johnson. Pfizer is currently approved for ages 12 and up, and we have several trials that are ongoing for the pediatric population, and we should have more information on that. Really quickly, the Pfizer BioNTech vaccine trial was over 43,000 participants and 95% efficacy reported. And the Moderna was about 95% efficacy as well, 30,000 enrolled in this trial. This is just a simple comparison side by side, very comparable. And if you look at the breakdown of ethnicities as well and most common side effects reported, both Pfizer and Moderna trials did release their information on the demographics of the study participants, really tried to have good representation nationally and globally. And then Johnson & Johnson Ensemble trial was a trial of about 60,000 people that, this vaccine was a single dose vaccine and could be stored at refrigerated temperatures. And, this was very helpful for people that were reluctant to go in for the second dose. But recently, we started hearing some information about rare cases of thrombosis. On April 12th, approximately 6.8 million doses of Johnson & Johnson vaccine had been administered in the U.S. And the CDC and the FDA were reviewing data that involved 6 reported cases of a rare severe type of blood clot in patients after receiving the J&J vaccine called cavernous sinus thrombosis. On April 13th, the FDA actually began a pause for this vaccine out of an abundance of caution. And in the time that the pause had started, and in that time from previous vaccinations, they had accrued total of 28 cases that were identified out of 8.7 million doses, which were administered in the US. On May 11th, the CDC said on its website tracking that the latest cases that the known potential benefits of the vaccine continued to outweigh its potential risk. All 28 confirmed cases occurred before the pause began on April 13th, according to the most recent presentation by the CDC. And the median age of these patients was 40, and their ages range really from 18 to 59. And of the 28 cases, 22 occurred in women and 6 occurred in men. So, what we know about this topic is basically these are the updates that were presented on those rare cases of cavernous sinus thrombosis. And this syndrome was actually called thrombosis with thrombocytopenia. So it's really important for us to know the signs and symptoms and to be aware of this, especially as people are continuing to get vaccinated. Most commonly occurs about 4 to 30 days after vaccination. Peak incidence is about 6 to 14 days. Women median age was about 40. As I mentioned before, and the symptoms that people were coming in with were severe headaches, visual changes, abdominal pain, nausea, vomiting, back pain, leg pain, swelling, shortness of breath. How do you triage these patients? They really need urgent ER eval. You need certain blood work done, CBC. You need platelet factor 4 to be done. You need fibrinogen D-dimer imaging. Treatments very different. You have to have high clinical index of suspicion. So history taking is very, very important for this, that we ask patients about their COVID-19 vaccination status and the time frame. Now, again, as I mentioned before, that the ACIP had reviewed all of this data and updated the EUA, which now includes a warning that the rare clotting events that might occur after vaccination, primarily among women aged 18 to 49 years old, and that patients and provider education about the risk for TTS with COVID-19 vaccine, especially among young women under the age of 50. And patients should be counseled on availability of alternate COVID-19 vaccines, and to really have that conversation with patients and physicians about making the right decision for what's the right vaccination for the patient, and the signs to look for an early recognition and management of TTS. Since April of 2021, there have been some increased reports of cases of myocarditis and pericarditis happening after mRNA COVID-19 vaccines. These were mostly occurring in male adolescents, age 16 years or older, mostly occurring after the second dose. There were about 17 boys actually, that reported getting myocarditis after COVID-19 vaccines, all of whom have similar symptoms, timings, and outcomes. In roughly about 5.8 million doses had been administered to adolescents between 12 to 17 at that point. The common symptoms were chest pain 4 days after vaccination. 5 patients had fever. Patients had rapid resolution of symptoms, which was really important to note. They were all treated with NSAIDs, IVIG, or steroids. They all had negative SARS-CoV-2 PCRs. But most importantly, there was no causal relationship between vaccine administration and myocarditis. So this was really important because, again, any unusual side effect or symptom should be reported to VAERS, and the CDC, the FDA, ACIP, everybody's looking at things with a very fine-tooth comb to see if there is in fact any causal relationship between vaccines and any of these atypical incidences happening, more than what we would see generally in the community at this time. So moving on to variants. Most of you may have heard that the WHO actually has changed the nomenclature of the variants to use the Greek alphabet now. Previously, we were using the Pango lineage, but very commonly people were referring to them as the variant from the country where it was first discovered. And this can lead to significant barriers and prejudice. And so it's really important that we use the appropriate terminology. So we have variants of concern, variants of interest, and variants of high consequence. So variants of high consequence, basically these variants are really significant in the sense that they can evade diagnostics, they can evade vaccines, they can evade any therapeutics that we have. Usually these variants produce more severe clinical disease, increase hospitalizations. Good news with that is that we don't have any of those. So that's at least something positive. And hopefully we keep the virus from circulating so we never run into that problem. But basically looking at the variants of concern, you have the alpha, which is a B117, which was first in the United Kingdom, the beta B1351, first in South Africa, the gamma P1, first in Brazil, and the delta B1617, which was first in India. And then moving on to variants of interest, we have, the ones from California, epsilon, which was the B1427, B1429. The New York variant is iota, the B1526, and then you have these other variants of interest as well. And if you look at nationally, if you look at our distribution, basically these are the variants that are most prevalent in our community right now. We can see we had predicted that B117 would probably be dominating, and that is the predominant variant that we have circulating in our community. And if you look at from the CDC, the number of reported cases that we have right now of these variants in our communities, you can see the B117, you have about over 20,000 of these from 52 jurisdictions, and the B1351 is 453 of these, and P1 is 497. Again, these numbers could very easily be underrepresentation. We are still ramping up our genomic surveillance and sequencing, but it gives you a rough idea. Lastly, I did want to mention with the variants is that the Delta variant, which was first discovered in India, is highly transmissible, about 60% more transmissible. And we can see that there is a significant increase in cases in the UK from this, not just in India, but in the United Kingdom in this past week, their cases have gone up by 90%. So the Delta variant has increased to about 6%, probably more than that, again, based on genomic surveillance in the US, but something for us to keep an eye on, and why it's really important to continue to vaccinate so that we can keep these variants from not circulating and not becoming predominant. Now, if we look at the number of people who are vaccinated, this is recent from the 7th, 2 days ago. We have over 300 million vaccine doses administered. Over 139 million people were fully vaccinated. This number is obviously higher, but this just gives you a breakdown of the total population, the percent population that's at least one dose, about 52%, and fully vaccinated, 41%. That was as of Monday. Now, if you look at the rest of the world, you can see that, these areas, the darker areas are where there's significant vaccine distribution and allocation and administration. And then you have the rest of the world. So you have about 2.15 billion doses that have been given worldwide. And that's really enough to fully vaccinate about 14% of the world's population. What's really sad is that less than 1% of COVID-19 vaccine doses globally have been given to people in low-income countries. So again, if you look at the countries that have fared well in the vaccination campaign, you can see who's really vaccinated the most of their population on this graph. You have Israel, United Kingdom, Bahrain, and you see United States is over here, and and we're somewhere over here at this point. But as you go farther down and down and down, you see, in India over here is only 3.2% of their population. So really significant inequities here. And you can see just on this world map that there's, COVID-19 vaccine policy, the same way we had started out when it was a supply and demand issue, where, we had to risk stratify who was going to be eligible for vaccines first. And based on that, we were able to give the limited supply of vaccines to those people who are most vulnerable first, and then give it to other people. Now that we've ramped up our vaccinations, anybody is eligible based on, age, and it's essentially available to anybody who is eligible. So this is not the case worldwide. The problem with vaccine inequity is that you can continue to have ongoing transmission and the risk of new and emerging variants. And for the pandemic to really be under control, most of the world really needs to be vaccinated to get the transmission levels low. It is going to be endemic for years, but we are going to see these intermittent surges and outbreaks, since some low and middle income countries are not even expected to have access or ability to vaccinate individuals through 2022, possibly 2023. So key in this pandemic for us will be how quickly we control these outbreaks, and how do we prevent these surges. The recent news also out of the Biden administration was that 80 million doses of the COVID-19 vaccine are to be distributed globally by the end of June. 75% of the first 25 million doses will be going through COVAX, which is the international distribution system aimed at helping vaccinate people in the poorest countries. So this is, good news. About 6 million doses to South and Central America, 7 million to Asia, 5 million to Africa, 6 million again to Mexico, Canada, South Korea, West Bank, Gaza, Ukraine, Kosovo, Haiti, UN frontline health workers. Also, the administration removed contract ratings under the Defense Production Act, which prioritized U.S. contracts for suppliers to AstraZeneca, Novavax, and Sanofi. So what this means is that basically the US-based companies that supply these vaccine manufacturers can make their own decisions on which orders to fulfill first. So again, vaccine inequity is really rampant globally. And, for anybody who has access to a vaccine, they should take it. And we should continue to supply vaccines to the rest of the world, because, if there's COVID anywhere, there's COVID everywhere. Now, looking nationally at our cases, we have been in a sweet spot. Our numbers have been going down significantly, and that is very good from the vaccination efforts. But, recently CDC released MMWR study, which showed that hospitalization rates among adolescents aged 12 to 17 had increased during March and April. Although, the rates in adults at that time had plateaued or decreased, and that was mostly because of vaccinations. So we have to remember that we need to vaccinate adults and adolescents to really return to normal activities, whether it be schools, camps, social activities, travel. We have to keep moving that needle and keep getting people vaccinated, because not only were adolescents hospitalized at higher rates, but they were also, had ICU stays. So, we really can prevent all of that, and we should. So the current 7-day average in the United States, again, more good news. We've been seeing decreasing cases, roughly about 14,000 cases, which is a decrease of 35%. And if you compare this to our highest peak in January of 2021, we had over 251,000 cases at that time. So again, this is good news that we will certainly welcome. Now, lastly, just to give perspective again, that we are in a good place right now in our country, but, we have to look at globally again. We have to always keep thinking globally, because at the beginning of this pandemic, we thought this was not something that can, happen to us. It's happening elsewhere. And very quickly we saw, that this was a reality. And, we can see right now the impact that this is having in India on the top right. You can see the impact in South America, Brazil on the bottom left. On the bottom right is, the variant of concern, the Delta variant, which is circulating in the UK. So, all of these scenarios are possible once again in our backyard. So we have to keep our guards up. We have to continue to vaccinate, and we just don't want to let this virus to keep transmitting. So this is really important, and it's really important for us to remember that the lessons learned from this is that we were really ill-equipped to handle this pandemic nationally and globally. Global collaboration is really key. Depoliticization of pandemics is necessary, and equity has to be at the forefront on all aspects of the pandemic. And I think those are things that we have to really keep in mind as we move forward, because these are things that we're really lacking in our pandemic response. And this is, how we're going to build a better tomorrow.
Thank you so much, Dr. Syed, again. I mean, that was I hope I didn't cut you off.
No, sorry.
Okay. No. Okay. No, but I mean that it's kind of crazy when you live through something, right, and then have it explained to you on the from the beginning. It's so much stuff that you forget, right, and almost maybe want to forget. But no, I mean, I think it's really important that you highlighted the reality, right? Like exactly like you said in the beginning, people come to us to get the full truth. And, you laid it out very well, especially the inequities in our system and globally too. So I learned definitely a lot more as well too than I thought. And so thank you so much for consolidating and, distilling it for us. And so just a real housekeeping thing for people who are trying to get CME, please let us know if you have any questions after you signed up, and, make sure you fill out the questions as well. We don't have too much time left over, and Masha, you answered, I think, a lot of lingering questions people still have. I guess the thing that I would just want to ask you too is just that, with we keep hearing that maybe we're not going to reach herd immunity, right? Or at least the time that we thought we would. So I know you left some parting thoughts already about what you would, what you want people to learn from obviously this whole pandemic. But for the people, let's say, who still don't want to be vaccinated, and then when, like you say, when you see examples of India and elsewhere around the world, what would you just want to leave people with who still say no?
That's a great question. There are a lot of people that are in the wait and see group. There are a lot of people who are in just the hard no group. And it's really difficult to really engage and have people see, except, a lot of times I used to say this, especially in the beginning of the pandemic, before vaccines were even in the equation, where, we just wanted people to do mitigation strategies. And I'd say, if I could just have them come with me to the hospital to see the suffering, to see the agony. And, we've been through it, we've lived through it. You see what's happening in India, you see the despair, the death, and people oftentimes feel like they won't have that consequence. It won't be so bad if they get it. It may be something mild, or that it's a hoax, and it's certainly something that I wouldn't wish on anyone. But the thing that's really important to remember is that we still don't have a cure for this virus. And, the vaccines are the strongest tool in our toolbox, more than a year into this pandemic. And okay, we have therapeutics, we have antivirals, we have steroids, but I still have patients that, are ending up in the hospital on a ventilator and dying because nothing is 100%, even vaccinations, they are going to protect you. But, this is the thing, that if your immune system is suppressed and you don't mount that response to the vaccine, then we can't protect you except if the people around you are vaccinated and they're not spreading the virus. And that's the best way that we can protect that person whose immune system is suppressed. So, what I would say to people is that this is a reality and we all want to get back to normal desperately. Right now, we are in such a sweet spot. Things are so much better nationally. And that's because of the climate and also, just basically the way that these viruses are, but the massive vaccination campaign and the significant efforts that we've made. And that's really why we're seeing the transmission level so low. The issue is that, this may be temporary. We can very easily see surges again. We may not. I pray that we don't get to the crazy surges that we had last, fall and winter, but it can easily happen again, especially with more transmissible variants. So all you need is for a person to not have that immunity and not be vaccinated for the virus to keep spreading. And so for us to really get back to normalcy, this is going to keep lingering on and on and on if we don't get, majority of the population vaccinated nationally and globally. It's really up to us to, we are so, we have so much benefits here and we are so privileged that we have access to, safe and effective vaccines. And it's readily available to anybody who's eligible at this point. You've got countries, like I mentioned before, who they may not even get it till 2022, 2023. You've got healthcare workers, frontline workers, essential workers who are constantly getting exposed and dying, and they have nothing to protect them. So for us that have that privilege, it's really imperative that we do the right thing, that we protect ourselves, that we protect our family members, that we protect our neighbors, and that we work towards getting our country back on track.
I think that, I think we leave it there. That's beautifully said. Thank you so much again, Dr. Syed, for the time. You've been, I mentioned this at the beginning, but you have really been such a source of information and, just hope during this whole thing. So thank you so much for always being here and, giving your time to just educate and put people at ease, right, during this very scary time. So we're really appreciative of you, and inshallah, I hope just for everyone, just again, words of wisdom from the experts, not from a bot, not from Facebook, just from an actual human who knows what she's talking about, actual doctor who knows what she's talking about. So thank you again for everybody who's paid attention, who's listened in. Feel free to watch this later on as well too. And inshallah, we're not stopping. We're going to keep on with this as well as long as COVID is around. So thank you all again. Inshallah, hope you have a good night.
Assalamu alaikum.
Assalamu alaikum.